Well, thank you very much. Since we will be trying to address a topic that probably will come very foreign to you, as you have probably not been involved that much in pediatric oncology or in global pediatric oncology. Oops. So basically this is our world, this is where we live in, and this is basically who we are. We are a very complex and heterogeneous group where different societies, different continents, different regions evolve in at different speeds and with different problems. To the point that we have now to face these demographic explosions in some parts of the world, with some areas of the world evolving in a much different pace than others. Now you see that close to half of the population in the world right now are in Asia, North Africa, Southeast Asia, whereas our population, basically the countries that we represent, North America and Europe, are more stagnant and probably representing less and less percentage of our population. To the point that basically this is where we are going. So we are going to a whole different landscape where our problems will have to be addressed, which is a world where close to 80% of the population will live in developing countries. And these disparities will continue to widen as we move towards the next 2 or 3 decades. So basically this is redefining the landscape where we live in, this is redefining who we are and the problems that we'll have to be resolving. So in this context is where we need to start thinking, what do we do as oncologists, as physicians, or as physicians working in the first world countries, what do we have to do for the rest of the world? Particularly with cancer. So how can we place cancer and the global health challenges? Then how we can place pediatric cancer as a global problem in these global health challenges. And finally, we'll try to address this question, what can we do, those of us here in this room? So let's start with this first problem. What is the place of cancer in the global health challenges? So, as you probably remember, in 2000, in September of 2000, the United Nations General Assembly set up this path, which was recognized as the name of the Millennium Development Goals. And so that was for 2015. We are past 2015, so it's 2015 and beyond. And there were 8 major goals that basically are all set up to basically fight poverty and what comes with poverty. So it is not only to eradicate extreme poverty and hunger, but also to achieve universal primary education, promote gender equality and empower women, reduce child mortality, improve maternal health, combat the major infectious diseases like HIV/AIDS, malaria, and others like tuberculosis, ensure environmental sustainability, and then develop a global partnership for development where all of us could be part of those goals. So when we think about diseases, how do these diseases fit into these Millennium Development Goals? So when we talk about global health, in general, we tend to think about infectious diseases, right? Communicable diseases. Global health has been defined by HIV, by tuberculosis, by malaria. And yet, when we look at the causes of death around the world, including low and middle income countries, actually it's non-communicable diseases that take the lead. So not only for our countries, but also in those with more limited resources, infectious diseases are taking a smaller percentage of those deaths. So basically non-communicable diseases are taking a priority right now or are going quickly towards the top of this priority list. So to the point that then 10 years later, in 2011, 11 years later, the same General Assembly of the United Nations at this high-level meeting decided to come up with a very strong initiative and proposals for prevention and control of non-communicable diseases. And 2 years later, the United Nations agency, the WHO, followed with a global action plan for non-communicable diseases with the goal of reducing 25% in the mortality related to NCDs by 2025. And that's basically what the United Nations or the WHO basically put together as the 9 global targets, basically to reduce by 25% the NCD-related mortality. And you will see that, right? It's about, use of alcohol, increasing physical activity, decreasing intake of salt, etc., etc. But what I'm pointing out here is that cancer is not a global target. Cancer is part of global target 1, which is 25% reduction in mortality from cardiovascular disorders, diabetes, chronic respiratory, and cancer. And yet, when you look at where cancer is, cancer actually is the second most common cause of death from non-communicable diseases globally, not only in pediatrics and adults, only behind cardiovascular diseases. So basically, cancer is taking a top seat in our ranking of causes of death worldwide. And so this is the cancer burden worldwide. Around 60% or so of all cancers are in low and middle income countries. We, in high income countries, North America and Europe mostly, have around 40% of all cancer. We'll talk later about pediatrics, but around 30 to 40%. Probably because we are an older population, and in countries with limited resources, the life expectancy is much lower. But what's important here is that the expenditure that goes associated with the care of patients with cancer is completely biased towards our population. So we have 40%, 38% of the cases of cancer, and yet we have 94% of the dollars that go into taking care of the patients with cancer. So you can start seeing what are the disparities when we address cancer. And that's not only about the patient care. If we look at the research gap, there is a major gap in research dollars spent to investigate cancer. So United States and Europe account for more than 80% of all the dollars, or have more than 80% of all the dollars that go into researching cancer. The rest of the world has around 17% at most. So that's basically a kind of a snapshot of all these disparities, where the patients are, where the resources are, and where we put our monies to take care of the problem. And what basically does is this is reflected in this figure, where basically the mortality is completely shifted towards the left. So that is where the countries have the least resources and the highest numbers. That's where also the highest mortality rates are. So basically you see that big imbalance between cancer numbers, cancer care, and cancer outcomes. So that's the big picture of cancer in our global world, if you allow me to say that. But of course, I'm a pediatric oncologist, and what I have to do is take care of children with cancer. So what is the problem in pediatrics? And the problem in pediatrics is basically much more dramatic than what we have seen for adults. I start by showing this picture. This picture is a historical picture from St. Jude in the 1960s. So for those of you that have followed, and probably very few in this room are familiar with the leukemia studies at St. Jude, but basically for many generations these studies have been called the total studies. Total 1, total 2, we're now by total 17. So this was basically the total team. So that was the team that in the 1960s, when St. Jude started working as a cancer hospital, put together their brains to develop treatments for kids with acute lymphoblastic leukemia. And here you have the first director of St. Jude, that was Don Pinkel. I will not go through all the other people, but basically this was the first director of St. Jude. And when I was a fellow at St. Jude, when I was younger and I was going over the library, preparing for a tumor board, I ran across a book where the fathers or the founders of pediatric oncology explained why they became pediatric oncologists. And Don Pinkel basically said this. His motivation was emotional rather than intellectual. Those children suffered agonies beyond the imaginable, but even worse, they were considered lost cases. They were ignored during rounds. Their essential needs were also ignored. The management of pain was also ignored. And the tragedy of those children was not as much their death as their abandonment. This was in the 1960s. In the 1960s, less than 10% of children with cancer would survive. And now we think that ALL is probably one of the most curable diseases, not just the most curable cancers. It's one of those diseases that we have been able to perfect, and we are curing now greater than 95% of children with ALL. So basically in our lifetime, over 5 decades, we have taken a disease from incurable, those kids that suffered agonies beyond the imaginable, to a disease that now is considered to be one of the most curable diseases in pediatrics. But what does this mean worldwide? What does this mean for the children? I just said that ALL is one of the most curable diseases that we have. Is this true? Well, this is not true. So if you look at where the kids with cancer are, around 82%, more than with adults. In adults, we said around 60% are in countries with limited resources. For pediatrics, just because the world has a younger population, 82% of the children with cancer are in countries with limited resources. So that's basically what Dr. Pinkel described in the 60s is still happening today in many parts of the world. So I go back to the Millennium Development Goals, but to remind everyone that Millennium Development Goal number 4 was to reduce child mortality. And this is where we are as pediatric oncologists. And so we have done major progress. So definitely through immunization, sanitation, improvement of child and mother health, we have been able to decrease the infant and under 5 mortality rates to the point that we have been able to cut, as a society, the mortality rate of children under 5 on half, or by half, since the 1990s. So that means that our children are healthier, our children don't die of other diseases. And this is important because basically this is reshaping what we know about childhood cancer worldwide. So let me go over this figure with you. So on the left, you have countries with limited resources, that's Africa, Asia. On the right is us, so North America and Europe. In blue, you have the incidence of childhood cancer, and we, for many years, we have recognized that our incidence is much higher, sometimes doubles the incidence of cancer, say, in Africa or in Southeast Asia. In red, you have the under 5 mortality rates. Under 5 mortality rates are very high in Africa, very low in North America and Europe. And see what happens when these two lines cross. So as societies evolve and societies improve their healthcare systems, sanitation, immunizations, and under 5 mortality rates drop, the competing risks for death during the first decade of life drop dramatically. And so that's when the incidence of cancer increases dramatically as well and can almost double for some societies. And here in green you have the cancer-related deaths. And the cancer-related deaths have this polynomial distribution. That means that they are very low in countries with limited resources because kids don't have cancer, kids die of other things. And it's very low for us because we do very well taking care of those children. We can cure 80% of those. The problem is as societies progress through this development arch, that then countries are not ready to take care of children with cancer. As their under 5 mortality rates drop, the incidence of cancer increases, and the mortality related to cancer is the highest here in the middle. As programs, as countries evolve and try to start addressing childhood cancer, and they cannot do it because they are not prepared for this new problem that they had not seen before. Bottom line is that low and middle income countries have 80% of the children with cancer and 90% of the children who die of cancer. So when we look at then the priorities in low and middle income countries, particularly when we try to place cancer in this inverted pyramid, We see obviously that communicable diseases take the priority, and that's how it should be. You know, vaccination, prophylaxis, sanitation, clean water, obviously. Then the non-communicable diseases, cardiovascular diseases, diabetes, obesity, these are preventable diseases, and cancer. But then pediatric cancer comes at the bottom of this pyramid. So one of the most important prognostic factors then for childhood cancer mortality is actually the government expenditure. So if the governments spend money into the healthcare system, we know that children with cancer will make it. If they don't invest money, we know that they will not make it. This is basically what you see here on the right. European countries, North American countries with very robust, very strong healthcare systems have much higher survival rates than countries that have much more limited investment. I just point this dot here, that's Vietnam. You can see very little investment into the healthcare systems, just because this is a picture taken from a hospital in Vietnam, in a room wherein at St. Jude would have one patient, maybe two patients. In most hospitals in North America or in Europe, I counted 16 patients, maybe 2 or 3 patients per bed, patients under beds, patients between beds, plus all the families. So that's the example of a society or a country or a region that has advanced very rapidly in healthcare, and now they are facing a problem that they don't know how to resolve, which is childhood cancer. So, but is this the only problem? No, it's not about only money into the healthcare system. The child with cancer in resource-limited settings has many other problems. Patients usually come with very advanced disease, late stages because the healthcare systems don't recognize them. Maybe 20, 30, 40% of the cases, we don't even know them. They probably die before they come. That happens, the same that happens with adults. Abandonment of therapy is dramatic. In many parts of the world, 40, 50% of the patients may get diagnosed, but then they will abandon. So that's a social problem that needs to bring medical anthropologists into the equation. So you have areas of the world in Latin America, in Africa, in Central or Southeast Asia, where the rates of abandonment can be 40 or 50%, and that's basically 40 or 50% of the patients that you may diagnose, but they will die. Malnutrition is another problem. Malnutrition can affect 50 to 70% of those children, and we know from studies that have been done that the toxic rates or the toxicity rates are much higher. The PK, the pharmacokinetics of drugs, is different, and patients that are malnourished have less chances of being cured. Supportive care is very deficient. Toxic deaths are very high. 20, 25% of the children die in the first few weeks of treatment. Many institutions don't have transfusional support or antibiotics. Nurses, we don't have well-prepared nurses worldwide that could take care of children with cancer. In many institutions, you could have a patient-nurse ratio of 15 or 30 patients per nurse. And finally, palliative care. When we think that 90%, 80% of these children die, and they don't have any way to be calm or to be treated. So if you look at where the doses of opioids go, I'm not talking only about children, but we talk about the world in general at all ages. 98.6% of the doses of opioids per day are going to North America and Europe, when the deaths are actually in the rest of the world. So you can imagine people dying of cancer, children dying of cancer, adults dying of cancer, and they don't have any pain management. So then, what can we do? What can we do to address this big problem? So this is the map of childhood cancer. We have seen in one of the earlier slides how the distribution of the world population is exploding in some parts of the world, whereas it's stagnant in others like Europe and North America. The same happens with childhood cancer. So basically, to summarize, 60% of all children with cancer live in this part of the world in Asia, basically Southeast Asia, Central Asia, and Eastern Asia, and Africa. So North America has less than 7% of children with cancer. Europe, including Russia and the former Soviet republics, is 10%. the rest of the world basically has the highest burden of cancer. And so Beth already introduced the outreach program that we have at St. Jude, and I will just show you a few things that we are doing and others are doing as well, and trying to address this problem in a very professional way, hopefully. So this is the mission of our program, to try to improve the survival rates through sharing of knowledge, implementation of new approaches, and generation of these research or interactive networks that I will try to describe in the next few slides. So over the years, over the last 2 decades, St. Jude has started these partnerships that we call twinning partnerships with around 24 programs in 17 countries, which may just represent around 2.7 now, or 3% of all the global burden of childhood cancer, which is clearly insufficient for what we need to do. And this is what we have always called the International Outreach Program, working with this twinning, this partnership, capacity building with individual institutions, try to advance through education, and that's with the goal of improving access and advancing care. But moving forward, we are going to be trying to develop a different program that now we call St. Jude Global. We don't call it anymore International Outreach Program. And the idea is that it's St. Jude, not one program, but everyone in the institution that goes global. So we have a Department of Global Pediatric Medicine, but then we try to bring all the other services, including diagnostic imaging. Dr. McCarville and Dr. Casti, they don't know it yet. But of course they know it. But the issue is that we as an institution actually want to be part of that. And so the idea is that all as a group go to the world, try to educate, build programs, and advance research. And I will just highlight these 3 components. The first is this program building, the twinning. We call twinning this kind of intense partnership, this one-on-one. And we twin at many levels to improve the hospital infrastructure, to improve the education of oncologists and nurses, try to improve infection control, develop evidence-based medicine, and the goal is to decrease abandonment, as we have discussed, but improve cure rates, decrease toxicity. This is the overall plan, trying to advance care for all these patients. And this is one of the first meetings that we had in some of these networks that we are creating. That's me much younger, as you can tell with my hair, but this was a meeting that we had in Honduras where we were just trying to put all the doctors from the region and discuss what problems they had and how to address them. We were at this hotel and the power went off, and so we went down to the lobby. We asked the people at the registration desk if they could turn the headlights of a car. And so we continued working, just looking at this, and I put this slide just because it's an International Cancer Imaging Society. So that's basically what we're trying to do, just review these cases or these CT scans. But the bottom line is that's how everything started, basically 20 years ago, just this one-on-one, case by case. This has evolved over the years. Now we have this region that we call AHOPCA. All these countries got together into this association, this network, like a consortium, all the countries in Central America and the Dominican Republic, and many other institutions now have come in, not only St. Jude, but institutions in Boston, in Colorado, in Toronto, trying to help, and also in Italy. So now the AOPCA group is like a small consortium, both for education and research, with initiatives at different regional levels in nutrition, nursing, infection control, but also disease-specific protocols, like any consortium would develop an ALL protocol, a Hodgkin's protocol, etc. And that leads to guidelines and research studies. And so this is basically how these twinning partnerships go. So this is the challenge that these twinning partnerships try to resolve. So first we have the hospital and the pediatric oncology units. The pediatric oncology units, as you can imagine, have to work with a very complex disease, complex set of patients, very time-consuming, very expensive, very resource-intense. And then you have the government, the hospital administrators, basically, that deal with very high volumes, with many other priorities, with changing governments, with cutting or restricted budgets, political changes, etc. Bottom line is that what we try to do, or what our partners try to do in a country with limited resources, doesn't fit that well with what the priorities are at the level of the government hospital. So here is where we try to be, us and you, right? So just try to work with both parties and try to be the, let's call it the emulsifiers, right? The catalyzers. Just try to set up priorities just to cover parts of the budget when the government cannot do it. Try to improve leadership, trying to, educate, just try to alleviate some of these frictions between the two. So that's basically what we try to do as the third partners into this. So what are the limitations of this one-on-one? So these twinning relationships have a limited reach because we concentrate all the resources in one country, in one program. We need a lot of components, the foundation, the hospital administration, the government. We may not be able to build capacity at the regional level, and we may be underutilizing some of the regional resources that might be available. Then, by doing this twinning one-on-one, we may not be able to favor the cross-fertilization, so between countries or between programs within the same region. So basically, that's what we are trying to do. We move more towards a regional approach, and I show you this slide again, just to point the fact that basically countries move together with their neighbors, so the regions will work together. You seldom do you see kind of a standalone country within a specific region. So basically that's what we try to do. Regions are basically the next unit of work. So regions have similar language, socioeconomic frameworks, political systems, belief, religion. They have the same problems, the same regional solidarity that sometimes we forget. So what we're trying to do right now is build these regional hub models where we try to enhance these concepts of capacity building, education, and research within the region, with key components that actually go across the region and try to benefit everyone. We have developed the region that I mentioned in Central America. We're developing now another one that we call POEM in the Middle East and North Africa. We have already one in China, and we're developing a few others in Latin America and in Southeast Asia. So that takes us to the next topic, and I will try to go quickly over this over the next 5 minutes and try to wrap up. So twinning is a big component, so this partnership, but I think that the next big component is education. We need to be able to educate everyone. St. Jude now is a graduate school as well, and in combination with the graduate school, we're implementing several initiatives to improve capacity or to work on capacity building. First, we're developing a global health track in a pediatric hematology oncology fellowship, and we're creating a master's degree that we call St. Jude Global Scholars for many doctors from around the world that actually will take and so be what we call a St. Jude Global Scholars with a master's in global health. But what I like is this other concept that we're trying to create, that is the St. Jude Global Academy, which is a certificate-based workshop kind of style training on campus and in all these regional hubs for pediatric oncology, for nursing, for subspecialties, and then global pediatric hematology oncology fellowships in 5 regions of the world where we will be training pediatric oncologists. And finally, a distance learning platform that supports all these initiatives across the world. So basically that's the 5 education programs that we have currently, mostly in Latin America, but also in the Middle East, and these are fellowship training programs. We have a nursing education program, we have a critical care education program, and now a bone marrow transplant education program. We're going to build 6 additional education centers in Mexico, Chile, Brazil, Lebanon, China, and Singapore to cover more regions. And so hopefully the expanded educational global impact will be much more visible. So we'll train doctors, train nurses around the world so that basically countries that are not even related to St. Jude can also benefit. And the final point is this one, research. So St. Jude Children's Research Hospital has research in its name, and many of you, probably most of you, work in academic centers. And we all know how important it is to integrate academia and research in our daily activities. So research is important when we do global health as well. And there are many opportunities, from epidemiology to medical anthropology to translational research, molecular epi, and many others. I will just point to one factor. When we talk about pediatric cancer, I always wonder, so, but what cancer are we talking about? We talk about our own cancer, the data that we have from our own hospitals, from our own registries. But if you look at cancer registration around the world, basically most parts of the world have very limited registration, so we don't have any clue about what cancers they see. What we see in our textbooks is our cancer, but we have not paid attention to these variations in the incidence of types of cancers that we see around the world, and I will show you just one example. So in North America and Europe, the most common extracranial solid tumor is neuroblastoma. That's very obvious, all our textbooks say that. When we started working in Central America, after many years of working, we developed protocols, we developed initiatives for almost all diseases. We realized that the only disease that we have not even touched was neuroblastoma. It was not because we did not want to, it's just because we did not see those patients. So when we started pulling those data and tried to get down to our registries, hospital-based registries, but basically these are national cancer centers, the incidence of neuroblastoma in Central America with a very unique ethnic kind of composition is probably 1/10 of the incidence that we see in North America and Europe. So basically neuroblastoma is one of the least common solid tumors actually in Central America and many parts of Latin America. So basically what we need to do is just first improve our reach to all this data. So we're building cancer registries, pediatric specific cancer registries in Latin America, particularly in Central America, to learn more about that. But then we need to learn more about what cancers do we see in the world in pediatrics. That's very obvious. In Africa, you will see burkids, but what happens in Southeast Asia, what happens in China, what happens in the Middle East, what happens in Latin America, and what are the biological bases for those differences that will teach us much more than what we think about the etiology of childhood cancer and how to treat it. So basically, to summarize, this is basically the three components that we feel are critical to build pediatric cancer initiatives worldwide. Try to advance through these levels, improve the capacity of all these countries, all these regions, all these hospitals. And why pediatric cancer? Well, because we are pediatric oncologists, but then also because if we teach a pediatric oncologist and a pediatric oncology unit to take care of children with cancer, somehow we increase the institutional self-esteem of these countries. They can do it. If you can take care of a child with cancer, nobody can stop you. There is no limit to what you can do. You increase the strength of your healthcare systems, and there is a contagious effect on other programs. If you can take care of a kid with ALL, why cannot you do a kidney transplant? So basically, these are the three main points that we have tried to address. And so this is basically what St. Jude is doing, the St. Jude Global program that had this international outreach program with 24 countries, 24 partners in 17 countries. We said around 2-3% of all pediatric cancer. Through these regions, we're building this new structure we call the St. Jude Global Alliance, building regional powerhouses and institutional kind of relationships to around 5 or 6 regions around the world. That's what hopefully will help us advance or at least touch the lives of close to 30% of children with cancer in the world in the next decade. So we put it all together, so we need to identify the problem, obviously, and the problem could be many different problems in one or different problems all together with late diagnosis, poor referral, lack of oncology units or health systems, and I'm running out of time. Then we need to set up the priorities with early detection campaigns, education of providers, building the programs, etc. Develop these partnerships, that's the next step. Have very good twinning or partnership models, good teams that provide advocacy and support, then develop these regional networks that we feel are so important, basically that you will never walk alone, like it's the fans, the hooligans for Liverpool call, I believe it's Liverpool, right? And then the growth, so how to improve what we have accomplished and how we can grow from there, and that's basically integrating research, developing new initiatives that are unique to the region. And so these three components are critical, as we said. I think that the message for everyone is that academic centers must assume responsibility. We live in a global world. All the children are our responsibility. Everyone in this world is our responsibility. We need to change the philosophy in which we work. This is a new vision. Maybe we need to bring new mission to our institutions, and strong commitment from everyone. This is not mission work. It has to be integrated within the programmatic goals of our universities and our hospitals. We need to educate everyone, from the students to the advanced trainees. Institutions have to commit to financial support, and that's how I think that we will reach the next breakthrough in pediatric cancer. So this is a very typical figure that we can all show. That's a breakthrough. So patients die in blue, patients survive in green and yellow, and this is basically using imatinib for Philadelphia positive ALL. This is a JCO paper, and this is a breakthrough. There were 44 patients here, 130 patients here. This is the same figure, but this will never make it to JCO. These are children with acute lymphoblastic leukemia in the Dominican Republic before and after this type of partnerships. Probably 300 patients here, 500 patients dead here. And this is the same figure, but probably with less relevance to the public. But that, to me, is the same breakthrough or higher than this one. So I would like to conclude and thank everyone in my department. In our group is a big group that is growing with faculty and program managers, educators, and administrators. And with that, I would like to thank you.